What do you think, guys? How do they fit in the context of allotransplant? They serve as a bridge to an allotransplant, or we can do cardiac post-allotransplant, or they're going to replace transplant?
Well, I think there's hope that this could replace allogeneic transplant, possibly for ALL. It's early days, again. What we know from different trials conducted at the NCI, also at Memorial Sloan Kettering, is that patients who've had an allogeneic transplant as therapy for ALL can safely have cells collected and CARs manufactured, CD19-directed CARs, and receive those CARs safely. So, it can be used after allogeneic transplant. Whether an ALL patient who's getting CAR T-cell therapy goes into a complete remission, whether that patient you should sit on and wait and see how well they do, or whether they should get a subsequent allogeneic transplant, that question remains to be answered, although allogeneic transplant is a proven therapy with thousands of patients treated with ALL, so we think we have to use caution to say this early on that it will replace allogeneic transplant for ALL patients, relapse refractory ALL patients.
We had experience in our center with the NCI using CAR DLI. The problem when you use DLI post-allo transplant to try to have a stronger anti-lymphoma effect, you very often get GVH, right? And then so here in a patient who had failed DLI, we actually got them CAR DLI, and then from the donor obviously, and then it was really interesting because we had 0 GVH. And we had some patient that converted back into CR with refractory large cell lymphoma. We presented at ASH. It was published in JCO recently. And I think this is something that, I agree with you, that the allotransplant would not abandon right away, because some of these patients, I think it's more like a bridge for patients who have been resistant to chemotherapy.
Let me throw something out, because I think there's often a common misconception. The vast majority of allogeneic transplants that we do are for myeloid diseases. And often people think, well, we're succeeding in ALL, and we're going to be doing this for myeloid diseases. And let me just remind everybody, and it's a simple concept, but it's amazing how often people forget this, that the antigens that are likely to be the targets of CARs, and certainly there are myeloid CARs under development, are also present on normal hematopoietic stem cells. So it's very likely we can live without B cells, but we can't live without myeloid stem cells. And so even if we have a myeloid CAR that's very successful at ablating that malignant clone, and maybe perhaps better than the combinations of anthracyclines and Ara-C, that we're going to actually have to do hematopoietic stem cell rescue or a transplant to fix that. So for sure, allogeneic transplant for myeloid diseases isn't going away anytime soon.
There is an ongoing trial of an anti-CD123. And it's a good segue to actually talk about the fact that there are some off-the-shelf CAR T cells, CAR T cells, and that are interesting because they basically remove the MHC and remove the T-cell receptor, and so therefore the allogenic off-the-shelf, they persist for a few months. And the preliminary data, that was this young girl that was treated in London with a refractory leukemia and who has been in remission for now quite a while. So
there's also one other major, we should mention, there's also one other major group that's developing CAR T cells, the University of Pennsylvania and the Novartis group, and they also have very impressive results. So Dr. Schuster has presented on multiple occasions their experience in large cell lymphoma. They use the 4-1BB construct, I believe. In their experience, they're using, Dr. Schuster is using various different chemotherapies in order to keep people in remission after acquiring the cells and prior to, as the conditioning regimen, prior to the infusion of the CAR T cells. And they've had amazingly durable responses in patients with refractory large cell lymphoma. You've seen that data.
You're right. I actually updated the data, presented data a few months ago again at ASH, and then I talked to him the other day, and then they are, once a patient has reached a CR in their series, and they're obviously all refractory patients, as we know, and poor risk patients who would do very poorly otherwise, and have had very durable response in over a year, and in patients who have refractory large cell lymphoma with no further therapy. So I think this is really exciting. Yeah. They also were the first clinical data were from UPenn with the CLL, and it was a heavily pretreated patient, 3 patients if I remember well, but they responded pretty well.